At this EHA meeting, we're presenting a poster on the phase 1b study of the sequence of administration of Ibrutinib plus Obinutuzumab in patients with relapsed or refractory CLL. So this regimen of Ibrutinib plus Obin has certainly advanced quite quickly in the last couple of years, particularly as illustrated by the Illuminate phase 3 study, which led to the frontline approval of this regimen in the United States. And this is a nice treatment option for our patients in the frontline setting. But there are some data gaps with this regimen, one of which being what is the optimal order of administration of the drugs? We know that Ibrutinib can blunt some of the cytokine and chemokine responses that can lead to infusion reactions with Obinutuzumab. And so this is one of the first studies that's looked at specifically the order of administration of these drugs to see if there's an optimal way to sequence them. Another data gap is in the relapsed refractory CLL space where we don't have much data at all on this combination. And so this study was designed to kind of address both of those needs. So in total, we have accrued a full study now of 52 patients. The initial part of the study randomized patients to one of three arms. In the first arm, patients received a month of Obinutuzumab as a monotherapy, followed by 6 months of Ibrutinib with Obinutuzumab, followed by Ibrutinib given until time of progression or unacceptable toxicity. In the second arm, patients started with Ibrutinib as a monotherapy for 1 month, then did the combination for 6 months and continued on Ibrutinib. And in the third arm, patients started both drugs simultaneously, as is typically done, for example, in the Illuminate regimen, and then continued on Ibrutinib after completing 6 months of combination therapy. So in the initial portion of the study, we randomized 10 patients to each arm. And we did see significantly higher rates of infusion reactions in arm A, where we started with Obinutuzumab as a monotherapy. Actually, close to 60% of patients had this infusion reaction problem. In contrast, the infusion reaction rate was quite low in arms B and C at 5% and 19% respectively. And so as we expanded the study, we closed arm A and only accrued additional patients to arm B and arm C. As we went on to treat these patients, we saw a very consistent toxicity profile as what we would expect from the two drugs on their own, with the notable exception that in arms B and C, we saw lower rates of infusional reactions from the Obinutuzumab. And from the efficacy side of things, we certainly saw promising data there as well. In the entire cohort, the overall response rate was 92%. And I think pretty strikingly to us, if we look by IWCLL criteria, including bone marrow biopsies, we saw a 44% complete response rate in this overall population of 52 patients. We also looked in a subset of patients where we had samples available at MRD analyses. And in an ITT analysis, 13 of the 52 patients, or 25%, had undetectable MRD in the blood, although many patients actually did not have testing for MRD. So if we looked, for example, at the 35 patients who did have testing, we had 10 of those patients who are undetectable in the blood, so about a 30% rate of undetectable MRD. The follow-up is relatively short at this point at 21 months, but we still are seeing a nice progression-free and overall survival with very few progression events at this relatively short time frame. The median 2-year PFS is 88%, and the 2-year OS is 96%. So I think this study, again, is informative in a couple different ways. One is in terms of the order of administration of the drugs. I think our randomized data do support the current methodology of starting both drugs simultaneously, although there's also a hint that possibly starting the Ibrutinib even a bit earlier, a month before, may be beneficial, but probably best not to start the antibody on its own before Ibrutinib. The CR rate of 44%, if we look at a similar time frame from the Resonate study of Ibrutinib monotherapy, the rate there was 9%. So I think that we do see likely a higher degree of complete response. Whether that will translate into a longer PFS remains to be seen, and we need longer follow-up to know that. This regimen also continues the Ibrutinib as a continuous therapy, and so it does not answer the question of whether these CR rates would allow for treatment discontinuation and a long progression-free interval off therapy. These are all potentially questions that could be answered in future studies, but we think that our study is certainly a good starting point to justify this future work.